Hi, dear friends and colleagues. This is a good case to show you all how intraoperative complications should be managed in a safe way. Once the stakes are high, it is important for you to calm your nerves down and manage those ADR spikes that happen in your bloodstream. Once you think the case has gone out of the bounds of your controls, it is always a good idea to take calm, take peace, and grab hold of the situation. Relax a bit and take use of your wiseness and your experience to manage the case well. So I've stained the anterior capsule with some dye. I'm starting the rexes. This is a nuclear sclerosis grade 3. Mind you, the objective of these videos is not to pinpoint my mistakes, which a lot of people do on this social media podium. The objective is simply to show you that these complications can happen to you at any part of your career and how to manage them safely. This is my humble request and a humble and earnest request for you guys to take these learnings home and not just pinpoint these mistakes out that if I would have been the surgeon, I would have done this, I would have done that. I'm a high volume surgeon in India with an operative number of around 500 cases per month. So, as you go on grabbing more and more experience in your career, these complications are inevitable and they are going to happen to you. So, I have dialed this nucleus up, and as you can see, the epinuclear cortical matter is disintegrated and fragmented at this point in time. And I'm going to take this out before impaling the belly of the nucleus. This is the key step number one if you are not good at doing a very good direct chop. I'm a big fan of modified direct chop as it uses horizontal and vertical components in chopping the nucleus in at least 4 pieces. This is my routine practice, and I have impaled the belly of the nucleus, and here you go. Simply, I have cracked the nucleus in the middle and just taking time out to crack it even further in 2 more pieces. And I want you to note what happens next. So as you can see, as I am about to grab the nucleus, and here you go, and boom. So what happened is the nucleus was relatively soft in this area, and as I went ahead and grabbed the nucleus was not there, and what happened is I just took out the bag from that area. I don't know whether this patient had some pre-existing zonular dehiscence, but I have made zonules weak in this section of the bag. It is around, 70 to 80 degrees of zonular dehiscence that I have iatrogenically and mistakenly made in this patient. But nevertheless, I am feeling the AC dynamics still are holding really stable in this case. So the nuclear remnants, the nuclear fragments are still there in the bag, and I cannot stop the phaco. I did not think of stopping the case right here. Yes, the idea of filling the anterior chamber with visco came to my mind, but yes, I relatively felt confident and fine in completing the nuclear emulsification first and then putting visco inside the AC. It's all about how confident you are in going ahead with the case. If you feel underconfident in any of your steps, it is always a good idea to take your phaco probe out, put some visco, and assess the situation. So I have slowed down the video for you all to master the direct chop first. In the first few seconds, we are going to do a very good job, but in some diabetic cases that I have noticed a pattern, these are soft, crumbly cataracts, and they tend to cheese wire. You don't know. You can your phaco and your tip can overshoot a bit in the periphery, and this is golden tip, which tells you never to venture in the periphery. And just like that, as you can see, as soon as I grabbed the heminuclei, I was too superficial also. As you can see, I am too superficial in the bag, and I just grabbed hold of the fornix, and saner minds prevailed in this scenario, because if I would have been in phaco pedal 3 position, I would have done a big hole in the fornix or in the posterior capsule, and all the pieces might have landed on the macula right now. So once I was in pedal 3, I was in pedal 2, because I wanted to grab hold of the nucleus for chopping. I was not in phaco position 3, pedal 3. So that's why the case was solved. But it is not a safe case to go ahead. The patient is 40 years old, and it is our duty as surgeons to do a beautiful surgery that lasts patient his lifetime. So this is another important learning for you all. You should do a fabulous job that lasts patient a lifetime. So as you can see, 80 to 90 degrees of clock hours of zonular dehiscence is there, just opposite to my main port, slightly on the left side. So I'll be very careful in taking the cortical aspiration out in this area, because see, there is zonular dehiscence and the bag looks really weak in this section, and I felt really uneasy at this point in time. So I will put some visco first, and then just complete the cortical aspiration. I think I completed this cortical aspiration later, but I think it is a good time to put a CTR now. For new surgeons who have not put a CTR in their careers, you guys should learn to put a CTR in a normal case first. A CTR does not damage any internal structure. It You can practice one CTR in any of your normal cases, and I have told my OT assistant at this point in time to open a CTR, and CTR is a very easy job to do. All you have to do is to take a tying forceps, a straight tying or a bent tying, it is your choice. A straight tying is a better choice, and you put one eye of the CTR in the bag, just like this first, and you thread the CTR in the bag like this with your tying. And at this point, you take two dialers. You take one dialer in your left hand, and you take one dialer in your right hand. Both these dialers act as your hands, like your hands in the eye. So you take one dialer, you support the edge of the ring, and you thread one dialer in the eye of the CTR. And by mistake, I just lost the hold of CTR, and I was able to manage it again in the bag. And here you go. So you can see that the bag is stable now, and it was a good idea to not complete the cortical aspiration in the zonular dehiscence part. Once the CTR is in place, yes, cortical aspiration becomes a little difficult. I know that, guys, I know that, but it was a better choice to do the CTR job first and then go ahead with the cortical aspiration. The CTR is supporting the bag well in this quadrant, and I am just examining the part. You can see the rexis looks circular, the rexis looks strong, and this arrangement with the premium EDOF IOL that we are going to implant in this patient will last him his lifetime safely and beautifully. You can rest assured you did a good job. Unless the patient has a big blunt trauma in his eye, the CTR, the IOL and the bag complex are not going to go away anywhere. And just like that, we have just taken out the last cortical remnants there was. And yes, the bag looks beautiful, it is clear, and it is an open runway for me to put Johnson & Johnson Ihans EDOF IOL in this patient. It is always a very good idea to explain all the things that happened in the surgery to the patient also. This gives the patient confidence that yes, the surgery went fine. Little hiccups are inevitable, and still the surgery went fine and we were able to manage the complications well. Never hide these hiccups from the patient, as this instills even more confidence in the patient that he was in safe hands. So it is my habit to generally put the haptics in 12 to 6 o'clock orientation in these premium IULs. That way I can align the Purkinje images better to the center of the optical part of IUL. In this case, I have consciously implanted these haptics perpendicular to the zone of zonular dehiscence. Some surgeons put it in the same zone as zonular dehiscence, but I have noticed that the bag and the IUL complex feel really stable once you put the haptics in perpendicular to the zonular dehiscence zone. So as you can see, the optical part is beautifully aligned with the pupil right now. The pupil has come down to around 70% of its normally dilated size, and I am just in the last lap of the surgery. For all those friends, colleagues, and juniors of mine who appreciate my work and my hard work that goes into making these videos for you all, I would like you all to subscribe and like my channel. It gives a lot of help to my channel if you guys like and subscribe, and just it takes a couple of minutes to post these videos for your juniors also. These videos can help them later in future. And yeah, that's all from my side. I hope you like my videos. I'm going to hydrate the side ports and the roof of the main port and call it a day, call it a case. The patient got a vision of 6 by 6 partial and had plus 1.25 diopters of near ad because it was an EDOF IUL. The patient was able to manage 80 to 90% of the tasks without a rest biopic correction for the rest of his life. And it was a surprise for me. The patient came for second eye Ihans a couple of months later. Thank you. Have a great day ahead.